Good afternoon, everyone. My name is Tami Moore. I'm the co-director for the Center of Public Life at OSU-Tulsa, and I am so happy to welcome you to join my colleagues and I here on Changing the Narrative this month. Changing the Narrative is a monthly virtual panel discussion that focuses on race, equity, and beyond. This series is a partnership of the Center for Truth, Racial Healing and Transformation, the Center for Africana Studies, the Center for Poets and Writers, the Center for Public Life, and the Center for Family Resilience, all of which are based at OSU-Tulsa, along with our friends at the Tri-City Collective. Today's topic is reproductive health in the Black community. I would like to introduce to you our panelists. Dionne Lambert is the godmother of the May 6th initiative and program coordinator at the Center for Public Life. Kristi Williams is the chair of the Greater Tulsa African American Affairs Commission. Angenette DeBose is with the Mayor's Office of Resilience and Equity with the City of Tulsa. Marshann Merrick will be joining us soon. She is on the faculty in the School of Health, Counseling, and Counseling Psychology at Oklahoma State University. We have two other partners as well. Greg Robinson with Standpipe Hill Strategies. Greg has had a death in his family and will not be able to join us, so we are sending our thoughts to him and his family today and holding up the memory of his mom and his presence in our space. And then we will also be joined for a short time today by the other godmother of the May 6th initiative, Gloria Thomas. Gloria is a practicing nurse, so she'll be joining us from her day, but we thought it was important that both she and Dionne have a chance to be with us today to tell the story about how this initiative started. So with that, as I said, Dionne is the godmother of this project, and it all began with an experience that she had in April 2021. So Dionne, let's start with your story.
Thank you so much for that introduction. And I'm going to say, I'm going to be myself in this, in our time together. So I would not be myself if I did not say that it felt really weird hearing you be so formal. So I'm just going to name that. And so my experience started out about, let's say, 20 years ago. I had some pains that were going on, and it might have been 25 years ago now. Had some pains going on in my lower abdomen, and they were just weird. And I've always had, I started my cycle early, as is pretty typical, or, in the Black community, because oftentimes we have a lot of trauma that causes us to be a little bit more mature, even in our physicality. But that's a whole nother changing the narrative. So I started my cycle early, so I kind of knew what it felt like. And I just had this weird pain. And when I went to the doctor, I was telling the doctor that something was off. It was just not right. And I was dismissed. I had talked to several doctors. I was dismissed. They tried to explain it away, said it was something completely different. And each doctor said it was something different. And so that was, I knew with the first dismissal that was not right. But then with each new explanation, I knew they didn't have a grasp on what was going on with me. And I didn't know how to advocate for myself. I didn't know how to speak up and to insist on testing or to insist on, whatever I would need to get that diagnosed. And so it just was dismissed. So fast forward to, I would say maybe 2 years ago, I'd gone into the doctor because I'd been having some additional pain, and my cycles were extremely heavy, really, really heavy. And they told me, that I had fibroid tumors. So I'm like, okay, fibroid tumors. Now this was, there's a bunch of stuff that's going on in between. So I'm going to pause. I'm going to slow myself down because I feel myself getting it worked up into a lather. 10 years ago, I had gone into the doctor and they told me that I had fibroid tumors. I was upset because it hadn't been diagnosed earlier when I knew something was wrong. Then about 2 years ago, I had gone into the doctor and they told me they were trying to do all of these different things and told me that I wouldn't necessarily be able to have children and that I was, because of my age and all of these different things, again, further dismissed and then explained away. And then also kind of made to feel like it was my fault for not catching it earlier or not saying anything earlier when I had been dismissed 20 years prior. And so April of last year, 2021, I wound up having a myomectomy. And for those of you who don't know, that is a surgery to remove fibroid tumors. And this is after finally learning or getting the courage to advocate for myself, because my doctors prior to that were suggesting a hysterectomy. And I refused to have a hysterectomy. And it's like, oh, well, you don't need it because your age and all of this. So making decisions for me. I refused, and I was prepared to go to bat with the insurance company because they were saying that in order for me to have it, that it would be considered a reproductive surgery, like it would be considered like fertility treatment. And I fought against that because I'm like, why does keeping my organ, an organ that I was born with, I should not have to have it removed because something is attached to it that shouldn't be. Remove the attachment and leave my organ intact. And so after finally advocating for myself in that way, had a myomectomy. When I had the myomectomy, they gave me 5 days of pain meds. I will say they removed 16 fibroid tumors from my uterus. 16 that ranged in size from a grape all the way up to an orange. They removed 16 of those tumors, so, and because there were so many, and because of the large size of some of them, it was pretty much a C-section, so it was not able to be done laparoscopically. They had to go in there and actually cut me open, and when they did, they gave me 5 days of pain meds. And when I spoke with my primary care doctor about it, he was taken aback and said, well, the federal law is that the maximum is 7 days. So why they only give you 5 days when and Tami was with me. She was, at that time, she hadn't gone into I had to hold her back, y'all, because she was ready to fight. But she was with me because I understood how I had been dismissed in the past, and unfortunately, I felt like I needed a white body present in order for them to hear me. And so she was prepared to do that, and she did that for me. And so on the 5th day of, I would say on the 6th day of me not having pain meds, because of previous situations and conditions, I have my medical marijuana card in the state of Oklahoma, and I had been, because I take it for arthritis. And so for pain, and so because I had run out of the prescription meds that the doctor had given me, I was trying, and then she told, the nurse told me to take a Tylenol. Y'all, yeah. My first instinct was, let me come run over your foot with a truck, and then you take a Tylenol. But so I had taken Tylenol and a gummy to try to to get my pain under control, or at least to take the edge off of the pain. And I was having this meeting. We had a meeting scheduled, the group that we meet with, and on that day was May 6th. And I explained to them the situation, what happened, and I was telling them how livid I was that I had gone through this, and that they had only given me 5 days of pain meds, and I was tired of being dismissed and all this other kind of. Tami will have more information about what actually happened in that meeting, because I don't remember. Because for me, whenever I have taken my medical marijuana, it's usually right before bed, so I'm going to sleep. So I had to do this and continue to try to function throughout our meeting. And I'll just say it was a funny meeting. because I remember seeing the faces and the laughter, but I don't remember what I said. So I'm going to pass it over to Tami now to tell the rest of the story and to continue the conversation.
Well, as Dionne said, we had a meeting. And the backstory is that a small group of us, Dionne and Angenette and some other folks that we were working with on another initiative through the center, met regularly on Thursday mornings. Dionne had her surgery on, well, as she had said, 6 days previously, and we were certain that we were not going to have this meeting until I get a text message at 8:55 a.m. prior to the 9 a.m. meeting. And she says, where y'all at? We need to have a meeting. Get everybody on the meeting. So we get on the meeting, and as Dionne says, I'm not calling her out. She says, I'm high, but let me tell you what I've been thinking. So she starts to talk, and she tells the story that she was just sharing, at the beginning of our program. And I thought, she is not going to remember this. I need to begin to type. So I want to read to you from the notes that I took from some of the things that Dionne said that day. So she told us that immediately after her surgery, she posted in a women's group that she belongs to on Facebook about these awarenesses that she was having about her body and her health and the way that she had been treated over time, and how that made her feel and how it led her to the moments that she was in that day. She said she must have had 900 people respond to her, and everybody and her dog that knows Dionne in Tulsa was calling, and she told everybody these stories. And she said, each time I tell these stories, I feel purpose being born. I feel some other aspect of my voice being shared. I had conversations with 2 different people last night, and the insight I got was that people just keep carrying this stuff, and they bury this stuff, and they don't deal with it. So I have an idea. I want to tell this story. She said, the tumors just get normalized, and the experiences don't get validated by the doctors that we see. Nobody asks why, because of medical racism. And then it contributes to poor health decisions, and the cycle continues. And then she mentioned someone that she and I both knew, Gloria Thomas, who I introduced earlier, and Gloria has joined us. And before I share with you the last paragraph of Dionne's comments, I think it's important for us to hear Gloria's story and hear about her experience with her husband, Preston. So Gloria, will you share your experience?
Hello, everyone. As Tami is saying, I just recently went through an experience with my husband, Preston Thomas, and he had pancreatic cancer. And the thing, he was having really, really bad back pain. And the pain was just so severe. And we, took him to his doctor, and he was, kept, taking aspirin and Tylenol, and they, and so we thought, we'll take you to the doctor and the doctor can, look at it. Well, when we took him to the doctor didn't really, think anything of it. We're going to send you to physical therapy. So they sent him to physical therapy. He did physical therapy for about maybe 2 or 3 weeks, and the pain was still just excruciating. It was still, just there and stuff, and he called me at work and he said, I'm just really in a lot of really bad pain. So I rushed him to the hospital, and there the internist doctor said, I demanded for them to do a CT scan, and they said, okay, we'll do a CT scan. And they did it. And they said, well, it looks like he has pancreatic cancer, and it's metastasized to his liver. And do you have a clergy? And I'm like, whoa, wait a minute. We haven't even, found out any information yet. We don't know, any prognosis. I mean, we're in the early stages. So the oncologist comes in, and he couldn't give me a prognosis because he didn't see what the internalist seen, and he just said, let's, get biopsies and things like that. And so we did, and it did ultimately turn out that it was pancreatic cancer, but it had not metastasized, like the internalist had said. So it just says, that the ER doctors should not be speaking of what is not really there, and, getting the families all in an uproar and everything and stuff until you really know what the prognosis is and what the problem is and stuff. You should leave that to your specialist and stuff, and we need to go through that process. So we did that and stuff, and then we had to wait, on the insurance, to approve his chemo. All in while he's still in agonizing pain. We found out this December 31st and 30th, and he didn't get his chemo started till February. He's still in a lot of pain. So, he finally got the chemo started, did radiation and did all that and everything. And then they said, okay, we're going to take you to surgery. He got approved for the surgery. He did the surgery and everything. And once the surgery was done, the surgeon said, I went in there, I clipped everything, and there, we're going to do some biopsies to make sure there's nothing else cancerous. That came back in a week, and he said, I found nothing else cancerous in there, but do you think, you need to go ahead and do your, do chemo just as a precautionary? Does your oncologist suggest that with you? And I said, he hasn't said anything. So I go back to the oncologist and me and Preston, and we ask him, are you going to do more chemo after the surgery? No, we don't need to do that. What do you want me to do? Kill him with chemo? We're not going to do that and stuff. We don't, we're just going to watch. And I'm like, watch what, what's going on and stuff. He goes, oh, don't worry about it and stuff. He's healed. Don't worry about it. Well, of course, we know, cancer is very vicious, and it, pancreatic cancer especially can come back with a vengeance. And it did. It came back, and it was, even more, had spread. And, here we go again. We find out in October, he's still having back pain. And November, they, are still telling us it's just scar tissue. It's just scar tissue. Don't worry about it. January comes, and we see the surgeon again, and the surgeon's like, I'm really worried about this scar tissue, that this, you're still in a lot of pain. I'm like, well, thank you. We've been saying that too, because we've been getting it pushed off that it's just scar tissue. And come find out, they do the numbers, and his numbers went from 14 to 257. And here we go again. It's January. We don't get treatment again until February, because we have to wait on the insurance. And I asked the surgeon, I said, so is this what you meant by, going and getting the chemo again and stuff? He goes, well, we're a team, and we decided to just go ahead and wait. I'm like, well, 2 of your team members were sitting on the sidelines. We didn't know that we were just going to go ahead and just wait and stuff. You should have asked us if we wanted chemo again. And we should have, did the chemo right after surgery, not to say, we don't know if that would have, helped or not, because we wasn't given that option. That option was taken away from us, and it was given, it was done by them, and they just decided just to watch and wait, and they gambled, and they watched and waited. And then 6 months later, August of 2020, my husband passed away, because it was so aggressive. It had moved from a level 1 to a level 4 within 18 months, and he's gone. So that's my story. And that's, why I'm so advocate about making sure that, people that are, advocate for themselves and for others, that they ask all the questions, and that they demand, things to be done in this, in different ways, because some people don't know. And they don't know how to, they just listen to the doctors and stuff. The doctors are human too. And they went to school. They don't all, get it, sometimes they're just up here, and they have like 2,000 patients that they have to see and stuff, and it's up to us to be advocates, because I kept saying, can we go to MD Anderson? Can we go to, get a second opinion? Always get a second opinion or a third opinion. And that's so important because, I believe that if we had, not been in pandemic or went to MD Anderson, that my husband still probably would have been here fighting, but he probably would have been, better, a little better off. That's what I believe. Because, I asked, if there's clinical trials out there. There's so many clinical trials out there for pancreatic cancer. I see them come up on my screen all the time. I still get emails from the PanCan network and stuff, and this doctor did not want to try any of the clinical trials. He said he tried one and, that would work, but, it worked for a little while and stuff. I believe that he should have released him to go on to someplace, that knew and had better outcomes with the pancreatic cancer. Don't, just because you've had one or two pancreatic cancer patients doesn't mean that you're an expert on it and that how it acts and how it does and stuff. That should have been, to me, should have been passed on to somebody that was more expert in that field of that pancreatic, of cancer. So, but that's my story, and I'll pass it back over to Tami.
Thank you for sharing that story. I think of this in light of a statistic that I read recently where somewhere in the neighborhood of half of the white medical students and residents, when surveyed, indicate that they believe that Black people experience less pain than white people do. That study gets repeated regularly and the numbers don't change much. As Dionne said, I had the experience of being in the office with her as she was preparing for that surgery, and I couldn't believe some of the stuff that I heard her doctor and her surgeon and his nurse say. I remember walking out to the parking lot and calling my wife and saying, you know what, it's a good thing that it wasn't you in that room, because I tried to act nice and not embarrass Dionne in public. I've been really struck by the number of people who say, yes, I had a similar experience when we talk about this. And that really comes back to the final thing that Dionne said that morning on our meeting. So, as Dionne's story, Preston's story, the experience that Gloria just told us about, the tumors do just get normalized. There's a sense that Black people don't really feel pain. I don't know how people say that with a straight face. The experience doesn't get validated, as we've heard, and people don't ask why. It leads to poor health decisions across the community, across the Black community. And what Dionne said, she went on to talk about this, that it all begins with the doctors. That she told us that morning on May the 6th, 2021, I want to tell my story. I want to tell it in a holistic way. I want to back it with research and with data. I want to share the true numbers. I want to weave my story with those of others who have experienced this. But I don't know how to do research, she said. But that's okay. And she had this big smile on her face. It's okay, because I know people at a research institution and I can partner with them. Well, the person, at least one of the people she knows, is me. And I really felt that day called into this work. Like I had been given my job. And I didn't know what on earth I was going to do about it. So I began to think about who are the people that I know that study maternal health. Well, let me email and connect her to this person. Let me connect her to that person. But they were all people who were studying things. They weren't necessarily people experiencing it, and they were not folks that were connected with our med school. So I continued to wonder how we would make this happen when into our lap fell an invitation to apply for a grant. And I'm going to be a little sketchy about the details for a reason that'll become a little bit more obvious here in a minute. But I got invited, I received an invitation to skip the letter of intent process and just submit a proposal for this grant. And the grant or it has been designed to support community research on health equity issues that can be addressed through health systems. Well, crap, that sounds like what we're doing. So I think I squealed and then emailed everybody and said, let's put this grant in. There will be more news to come about that. Watch the OSU website, and I hope you see our faces, some combination of the 5 or 6 of us on this project on various radio stations and TV stations in the area as the work continues over the next 3 years. But we have been funded. And the May 6th initiative is not just this dream or conversation that other people are part of. It's work that we're going to do. So as we got started with that work, I want to make sure that Angenette and Kristi have a chance to speak into this. So Angenette, you were on that call. Why did you say yes?
I said yes. And the first reason I said yes is because Dionne's story, unfortunately, is not unique. And I've been through it. I know others who have been through it. And so if there is something or some type of research that we can find inspiration or information on, that is something that I would like to be a part of. And as a city employee, you know, I work in the Moore office, the Mayor's Office of Resilience and Equity. And in that office, we are trying to dismantle roadblocks. We are trying to dismantle problems that are happening. So if there is a health equity issue, we want to shine a light on that to see if we can't bring the right people to the table to dismantle those types of issues. And that's why I got involved.
Kristi, I don't think it was very much longer after that first meeting that Dionne and I reached out to you and said, Miss Kristi, we need you. Why did you say yes?
I said yes because Diane's story connected with me in so many ways. As a Black woman who has dealt with fibroids and just the mistreatment as well in the healthcare that I've recognized. And I have not always been outspoken about that. And then just hearing it from a lot of different women in the community. And so I knew that I needed to get involved. And Tami, as you were saying that white people don't think that Black people has a tolerance for pain. You know, that has been the case since slavery and the mistreatment to women and using them as probes and science experiments. And unfortunately, like you said, that misconception of us exists today. And we have to do something about that. And even in this country, I mean, we didn't become citizens until 1868. And we still have not had equal access to laws in this country. And unfortunately, we have unequal access and unequal treatment in our doctor's offices. And so we have to do something about that. And so that's why I said yes.
Mm-hmm. And I want to call out our colleague, Marcianne Oliver Merrick, who is my colleague at Oklahoma State. She, I can tell you why she said yes, or I'll tell you what she said when I asked her. She's had been very involved with the North Tulsa Community Coalition in the conversations that they were having in North Tulsa on the issue of maternal health. Marcianne is a public health specialist. She has been working in the area of community health workers at the state level, designing some of the training and licensing requirements at the state level, and was well aware of the need to collect these stories and work on systems change. And she said, these are the statistics. She came with, well, I guess I should say she showed up in my email inbox with attachment after attachment after attachment with statistics about Black maternal health. But we said as a group that we want to support Black women and Black mothers. We also want to support Black women who are married to men who are experiencing health inequities. For me personally, and I know for Dionne, Gloria's story and Preston's story were very present. So that's the reason that this project focuses on reproductive health and not maternal health. And to be clear about reproductive health, that is, it's not a gender thing. It's not only women. Reproductive health is about a particular stage in life. So I'm the educator on the phone or on the call. Miss Gloria, you're the nurse. In the medical system, how does one define reproductive health? What age range?
The age range for reproductive health is usually, I'm going to say between 18, starting at 18.
And continuing until when? At what point is reproductive health not an issue?
I would say probably 35. You can go into your 40s as well.
Mm-hmm. And my assumption is that for men, it might be later in their life.
Later in life, right.
Right. So we're hoping that by defining this project as focused on reproductive health, that we are reaching people across the Black community, across the lifespan, who have experienced inequitable health outcomes that are in some way related to their race or ethnicity.
I've even heard it spoken like we've got a doctor who's going to be consulting with us throughout the project.
That's Dr.
And
Randall Lewis at the OSU
yes,
Family Medicine Group.
yes, and reproductive health like spans from, so when a young lady gets her cycle, she is of reproductive age, whenever that is.
That is so true.
Most young women, exactly. Most young women get their cycle before they're 18. And then, through menopause or even post-menopause, going through that change, so that's a long span of time. And that's quite a longer period of time.
Mm-hmm.
Yeah, I forgot, because some girls do get their cycle probably about between 9. So that's, that will start it early. We've had some that, gotten it at 8. But I would say, the majority of them get it probably between 11 and 12 and stuff. You have those, kind of 1% issues that, get it at 9 or 8, but the majority of them do get it between 11 and 12. Yeah. And then, go through
I'm sorry, that leads into the whole, teenage pregnancy and all of that kind of stuff, because they're conceiving.
Right.
Yeah. So true. So true.
I see that Miss Pamela Vickers is sharing that she knows a boy who had a baby in the 7th grade. So this is something that we hope is defined broadly enough to really have impact across the community.
Yes.
I'd be remiss if I didn't mention we have 2 healthcare partners, or health systems partners, I should say. We're working with the folks at Ascension St. John's, and also Hillcrest has signed on and joined us. And what that means when we say they've signed on is that, I mentioned earlier that this funding that we've received is supporting community research that's going to drive change at the systems level. Both of those hospital systems have agreed to commit to the work of helping us gather stories about people's experiences, and then using those stories as the basis for changing policy and practice within their systems. I've said all along that personally, I'm really interested in seeing what we can do at the end of that 3-year project in the way of incorporating some of this information that we'll gather into medical school curriculums. Now, I want to be really clear. That's Tami Moore saying that I really hope we're able to do that. I am not in any way speaking on behalf of OSU or our med school, but know that that will be, that's going to be my next kind of window of advocacy as this one is opening. So I said, when we were planning the other day for this call, and as Dionne was saying, I was very formal at the beginning of the talk. That was my Dr. Tami Moore voice. It's not the voice that these guys know really from me. It's certainly not the person that shows up on Thursday mornings for our weekly gatherings for the sister circle, as we call ourselves. So when the sister circle was gathering,
we can't call us a sister circle because now Greg is a part of it.
Oh,
Sisters in them circle.
Sisters in him.
sisters and them.
The sister him.
Right, sisters and them. So the circle gathered on Thursday morning last week, and we were talking about today's session. And I was saying, I really have a desire to open this up, and I don't want to ask all the questions. So I'm curious, Kristi and Gloria and Angenette and Dionne, what questions do you have for us as a group that you haven't gotten, you've not gotten an answer to in the year that we've been working together, but you want to talk about it while we're together today?
I want to ask Kristi about her experience in organizing and activism, and how what we're doing, what she sees coming as a result of this, with the knowledge and the experience that she has with helping to mobilize communities.
I think this storytelling is so important, and it's so important that Dionne, like yourself, that you were vulnerable enough to share your story to start this initiative. Without you telling your story, none of us would be sitting here doing this right now. So I want to acknowledge that. But that is really the spark to organizing. It starts with someone's story, and it starts with people coming together, not only to share and uplift that story, but how do we help to find solutions to that? And then once you start to share these stories, you get so many other people who have the same or similar stories. And so we mobilize them, and then we figure out, how do we organize everyone that we just mobilize, right? In order to advocate and to educate. And then the main thing is just to show them, I don't like to say empower, but because I believe if I, give you power, I can take it from you. And I think everyone has that power already inside of them to lead, to make change. And so that's what we want to do. We want to show the community who has been affected by these stories or going through a similar story that you have the power to affect change. And we organize the right people in the right places, the stakeholders, so that way we can say, okay, what are you going to do about this? And we're not going to let up on you until we get something done about this. And so that's really the whole, in my definition of organizing. And I want to just circle back and say, Dionne, I'm proud of you for sharing your story, because it's not an easy thing to do, and the courage that you had to do that. And I just see you helping so many women, and as Tami said, we're helping men as well, and specifically Black men and women who have been through this health system where their pain has been dismissed, abnormal symptoms has been dismissed, the lack of trust has skyrocketed, so they don't feel comfortable going through, to the doctor. They just go through the motions instead of really knowing how and having that relationship with your healthcare provider that you should have. And so because of that, I believe that we're going to make a major change in this community, and it doesn't have to just stop in this community. This can be broader because the issue is broader.
Yes. And people can get involved, and we want to speak to that. The things that we're going to be doing in the organizing cycle over the next 3 years will invite community members, people who are proximate to the issue, people who actually have influence and power in the issue as well, to collaborate in order to create systemic change, as Tami mentioned while she was talking. And so it's more than just telling the story, because people have been telling their stories for centuries and for decades. And so now we're getting to the point of not just telling the story, but we're putting boots on the ground, and we're actually putting people in action. And so Tami, Kristi, Angenette, Gloria, particularly Kristi, because of your experience in this, I want people to know that we're not just talking just to be talking. We're not just talking heads on a screen. Like, this is something we're announcing, that you have an opportunity to be involved and to be a part of the change. So what things do we see people participating in where they can actually become involved?
Well, we're going to have our launch coming in April, and I think that will be a great way to get people involved. And it starts first with education, because people need to know what's happening around them, right? Like just the fact, just in Tulsa, that Black families are 3 times as likely to experience death of an infant than white families through the lack of health care, through the discrimination in healthcare, because they don't feel comfortable, or their symptoms are being dismissed. Those things are important. We have a high rate of infant mortality, which is just, our city of Tulsa has identified that in our quality indicators. And I think learning those things will spark the action. So as we launch this and we have our actual main launch, we're going to get people together with these stakeholders in the healthcare field, and we're going to have to hold them accountable. We're going to say, look, these are the facts. This is how we're going to challenge you on these facts. These are the outcomes that we are wanting, and we're going to get them to help us to do that. And so that's how we're going to mobilize and organize this thing to really make a difference. And you're right, we're not just going to be talking about it. We are going to be on the ground, and we're going to be fighting for our communities.
So we had a question from the audience. Pamela Vickers asked, how do we distinguish between a doctor's lack of knowledge and understanding as opposed to a doctor's blatant racist responses, lack of compassion, and blatant neglect?
Great question. And it would be helpful to have a medical professional here to answer that question. But Gloria, what would you see as a distinct difference between being able to distinguish between they just don't know and they're either racist or biased? And there's a difference between racism and bias. Racism is intentional. Bias it's like that implicit, like it's like ignorance, and it's not ignorance in the sense that people say ignorant in a derogatory sense, like you just ignorant. No, you like literally do not know. So being able to distinguish between those two, Gloria, as you are working in the health field, how have been some, what are been some things that you've observed, or how would you speak to that?
I would say, just being observant, that, like certain people have different insurances, and they are treated differently because of their insurances sometimes. Like the Sooner Care, if you have Sooner Care insurance, Sooner Care doesn't pay as well. And so, they often kind of treat people differently because of that. And I'm always like, what difference does that make? It doesn't make a difference. There's still a human being there. There's still a patient there that you need to see. It shouldn't make a difference whether you get paid or not, or how much you get paid or not. So I've seen a lot of that, and I don't know if I don't think it's racism I think it's just a lot of bias because of what kind of insurance that they have that I've seen, because it can be black, white, blue, purple, and they'll still be like, I guess, I'm only going to get $2 today, because I've seen all these Medicaid patients, and they don't have, insurance like, Joe Blow over here, has the insurance and stuff like that and everything. And so, that's what I've seen a lot of, and it just hurts my heart because these, people, because of whatever their downfall is, has to have that insurance. They shouldn't be treated any different just because they have that type of insurance.
And that speaks that, that you bring up a really good point, that sometimes it's not necessarily racism, it's capitalism. It's the money, it's the dollars, it's the, but then that kind of but it does tie into racism because of the resources that we don't have oftentimes in our community to be able to access the same type of insurance and the same type of, quality of care. But, as a medical professional, though, that, like you said, that should not matter, because what the oath that they take is that they are caring for health, not, it's not about the dollar. But we all know that our healthcare system, especially in the United States, is jacked up.
Right.
To speak technically, to use a technical term, it's jacked up.
Yeah.
Yeah.
And just to add into that, it's like I've gotten a lot of patients that's come from, nothing against OU physicians, community, service that they have and stuff, but they have like, a lot of different doctors that they don't have a continuity of care. So the patients, when they see that one doctor, they may not see that doctor again because they're students or whatever and stuff, so they rotate over and over again, so they're not getting continuity of care, and they don't see just one doctor. So when we do get a patient from that facility or whatever and stuff, they're just like, oh, finally, we get somebody that understands, or that's going to follow us all the way through. My child's been acting like this for years, and nobody, I've not gotten just one person. I get 3 different people every time I go in. So,
yeah. So as we're talking about this, one of the things, yes, Kristi put a comment, and she's classism, racism, and sexism all happen in healthcare. It's true, that just because it's the medical field or the healthcare field does not mean that those things go away. It's still, because these are issues of our humanity, and as long as we have human beings who are operating in these roles, these things will come up. And so it's really important. And I think one of the, I have been, Dr. Moore is going to know as soon as I say it, but one of the books that I have been touting and promoting, in every meeting and every opportunity that I have, is called What Happened to You. And it is a book by Dr. Bruce Perry and Oprah Winfrey. And the subtitle of the book is Conversations on Trauma, Resilience, and Healing. And there's so much in that book that has to do with these kinds of things. And when we don't take a look at the whole person and we don't look at things in a holistic manner, then we are setting ourselves up for failure, and that includes the healthcare industry. And oftentimes doctors are not trauma informed. They're body, their physicality informed, but they're not trauma informed, and they don't consider these other things. And Dr. Perry in the book refers to a number of instances where the health outcomes were drastically different when that trauma approach, when a trauma lens was applied to a medical situation, because stress affects us in our bodies. And when we have certain types of stresses that happen in our body, they present in a way and that show up symptoms that if you're looking strictly at symptoms, you will misdiagnose because you're not looking at the whole picture. And so having an opportunity to look at that, that's important as well. And so I'm hoping that in the process of the next 3 years, and as we're working with and collaborating with our healthcare partners, that is something also that gets incorporated into what it is that they wind up doing in changing policies and practices and operations and things like that, because those affect our outcomes.
I think Pamela had another question too that was really unique. She asked about the insurance monster. And that's another, big thing, because as I said, that we had to wait for the insurance to approve his chemo, all while he's in pain. And one of them, they wouldn't approve one of them. So he had to have a, different one and stuff, and, they're, human beings behind that too, but they need to understand that cancer waits for nobody. They don't wait on insurance. It doesn't wait on, you to get anything approved or whatever. And people are, waiting on that, and the insurance needs to be held accountable too.
Exactly.
I think one of the things that's been the most exciting to me about this work is, as somebody who really, I'm here because I was called into the space to do the work. And I, at the Center for Public Life, we are very much committed to partnering with our community to leverage knowledge resources to support community-driven problem solving. That's a lot of fancy words, but what it basically boils down to is that we, and I'm looking at the list of attendees, and I see my colleague Mike Stout is with us today. So Mike co-directs the center with me, and we spend a lot of time talking about how do we take what we know and offer it as a resource rather than using it to identify a problem that we think people should be looking at. And this is very much an example of something that we are able to, come to as a resource and not the expert. The funding that we've received, the grant was specifically targeted at lifting up community members as researchers and acknowledging that people are experts in their own experiences. And, we've heard stories today from Dionne and from Miss Gloria, and Angenette and Kristi could have told their own stories. And I know Marshann has a story. I could, if I'd been writing down everyone I've heard, from the woman I met at the coffee shop to somebody at, breakfast the other day, those stories are the beginning of the work. That's how we will learn more about what's happened. Our partners at Ascension St. John and Hillcrest have said they really are interested in hearing from those folks who have these experiences, so that when they engage in the process of systems change, they're engaging in change that's targeting issues people have experienced, not experiences they think might be happening. We're really fortunate to have, I keep wanting to say, we're really fortunate to have the support of Organization X, The start date for the grant is April 15th. So on next month's Changing the Narrative, that'll be an incentive for you all to tune back in, because we'll talk a little bit about it during that call probably as well. So we've got 60 more seconds. I'd like to go around our Zoom space and invite my colleagues in one word. How are you feeling as we leave this space? And those of you that are attending today, whether you're watching on Facebook or you're attending in the Zoom meeting, let me invite you to think that too. What's one word that captures how you feel today?
I'll go with determined.
The word that Kristi does not like, empowered.
Since Ms. Angenette said that, I would say I feel self-powerful.
I would say inspired.
Shannon Chambers says she feels enlightened.
Shannon is a he. That's my friend.
Oh, apologies, Shannon. Shannon feels empowered. Hannah Alsabrook says she feels inspired. I feel grateful. I wish we had time to go around and hear words from other people. I hope you'll be joining us at some point during this work. Watch the Center for Public Life's website for updates as we're going along. And Pamela, I agree. There's a lot of frustration around the conversations, and also I'm grateful that people are interested in being involved going forward. So with that, today our time is up for this episode. It was wonderful to be with my colleagues and friends. I want to thank them again, Dionne, Lambert, and Gloria Thomas, the godmothers of the May 6th initiative. Kristi Williams, Angenette DeBose, my colleague Marshann Oliver Merrick, our colleague Greg Robinson at Standpipe Hill Strategies, and our partners at Ascension St. John and Hillcrest Hospital.
And all of you who joined us. Thank you for being here and listening.
Yes.
And now there's another drop in the bucket, and we're looking forward to those ripples going out. And
yes.
Yes,
Yeah,
yes.
I see people on the call from Stillwater today. It's really wonderful to have you all with us. So we hope that you all enjoy the rest of your day, and we'll see you next month on April the 19th at noon for our next episode of Changing the Narrative, which will be a roundtable discussion with the directors of the 5 centers that are involved with Changing the Narrative. We want to know more about the overlap. If we're a Venn diagram, what is it at the middle of the work that we do? So I hope you'll make time to join us then. And until that time, have a wonderful, wonderful day and a good March.
bye all.
Bye.